Well, thanks so much. My chore is in 3 minutes, infection prevention to treatment. So we'll giddy up through this. My disclosure. So it's interesting, when you look in the literature, there really are a breadth of strategies looking at how do we prevent infection. I also reached out to a number of high-volume colleagues and tried to ask them from what are their recommendations. But at the end of the day, a lot of it is borrowed from our hip and knee colleagues. And there really is no consensus. So there's a variety of pre-op strategies. Some surgeons like to do a nasal decolonization. A number of surgeons have gone to benzoyl peroxide as well, preoperatively for 3 days, as well as Hibiclens showers. In the OR, a number of different strategies, from Hibiclens wipes to using alcohol, hydrogen peroxide, and then ChloraPrep, one of my friends does. And the variety of antibiotics is across the board. Some surgeons like clindamycin, they feel it's better against C. acnes, Ancef, or vancomycin. This is another interesting one. In the time of surgery, one of my friends I spoke to, he puts the knife through the dermis and then stops and then uses cautery on the rest of the skin, which I thought was interesting, and then painting the skin multiple times during the operation. The thought is, once you cut through with the knife, cut through the skin, that the C. acnes is leaking in the wound during the operation. So what are the strategies we can use intraoperatively? You can paint the skin with betadine. You can irrigate throughout the operation itself. And then some surgeons have taken on what our spine colleagues do, like to use Vanco powder in the wound. But interestingly, some do that on reverse, but not anatomic, because they're worried about the effect on potential subscap healing. So the bottom line is there really is no overall consensus, but there is consensus on one absolute item, and it's the efficiency of the procedure is probably the #1 risk factor for infection. The longer the wound is open, the more times the door comes open to the operating room, the more people coming in the room, that is probably the #1 risk of infection. So working with the dedicated team the best you can, and the efficiency of the procedure is key. So how about if you're unfortunate enough to get a post-op infection? These are the 4 categories from our hip and knee colleagues that you can see there. So type 1 cultures. At Mayo, we tend to be aggressive about this. We have a dedicated orthopedic infectious disease team that follows our patients. I think it's key to keep all your cultures at least 14 days. We know that C. acnes typically doesn't grow sometimes between day 5 and day 7, so you can miss it if you don't keep your cultures for 14 days. So one pearl to take away from this talk. I think if you get that early postoperative infection, particularly now in light of a reverse arthroplasty, the thought of taking all the components out is concerning, so we'll try a debridement, a poly exchange in those patients, as well as that acute hematologous infection. It's interesting, the chronic infection, a lot of debate between 1 stage and 2 stage. I have to say in my practice, almost everyone that's sent to me has had a chronic infection going on for months. So in that setting, I do prefer a 2-stage procedure. Typically what we do at Mayo, component removal, 6 weeks of IV antibiotics, off for 2 weeks, and do the reimplantation at 8 weeks. So this is a classic example of an infected shoulder. If you see a loose humeral component, it's considered infected until proven otherwise. So this patient had a shift in their component. Compare the x-rays to the immediate postoperative one. This patient is infected. We put a spacer in there, and this is, get a CT scan, and then what we did is we go long to short. We don't like to use long stems. We like to use shorter stems. This is a trick I learned from Dr. Sanchez Sotelo that helps in the revision setting. So in the end of the day, when you think about managing the infection, it's the specific organism itself, it's the timing of the infection, and it's the host. Thanks so much.
So you just hit, stay up there, John. You just hit about 30 major topics in 3 minutes, and you had a lot of wisdom in there. First, let's just go to the audience. Raise your hand if you use benzoyl peroxide on your total shoulders. Smattering, right? Raise your hand if you use hydrogen peroxide. Little more. Raise your hand if you use dilute betadine.
Are you going to be ready to flip?
Smattering. Raise your hand if you use vancomycin powder in the wound at the end. So that seems to be the most unanimous. Bill, you want to make a comment for the judges or sequence?
No, go ahead.
But I want you to stay up. So let's start with T.
Of course, John always gives a great, concise talk. That's a 10. On my shoulders, I use a lot of hydrogen peroxide every layer. I do it pre-op, you know, before they prep. Cut the skin, hydrogen peroxide. Every time each layer, dilute hydrogen peroxide all through the case.
So is hydrogen peroxide sterile? There's this debate in ROR whether you have a sterile product or a non-sterile product, and whether you use dilute or rather can you use it? So our nurses get mad if we don't have a sterile product. They don't want to pour it onto the field. Do you face that issue?
We do not face that issue. I diluted it 50%.
Got it. You have a question?
I have my nurses put it through a sterile filter, and then it's sterile.
A sterile filter.
Like a 2 micron or some micron filter that goes in unsterile, and then it gets poured onto the field sterile.
Wait, Joe, got it. You better call him out on that one.
Do they burn incense at the same time that they're doing that?
All right. Bill, ask your question, then we'll go to Jerry after that.
So this is a question since we've moved to outpatient total shoulder replacement on antibiotic treatment, right? Because you used to come to if you stayed in the hospital, you got an extra dose while you're in the hospital or 2 extra doses. So are people sending patients home on oral antibiotics, or are they giving a second IV dose in the PACU before they're discharged?
So raise your hand, 1 dose. Correct, 1 dose pre-op.
And nothing post-op on it?
Raise your hand if you do post-operative IV in your outpatient
There's
setting.
a bunch of infections that come from Baltimore to me, from Auden and Murphy.
And then raise your hand if you continue them on an oral agent for some period of time. So Bill, it's a little, you know.
I think it's something to watch out for because you're going to start to see a blip in increased infections. My prediction.
But hang on, wait. But Bill, is there any data in any orthopedic surgery where, other than the preoperative dose of antibiotic, that it changes that risk?
No.
Not that I'm aware of.
Yeah. Mike Menachini wrote an article for Oxford.
So Gus, can someone throw Gus the mic?
No, I got one right here.
Or stand up? Yes.
No, Mike Meneghini wrote an article for the ACUS in the total hip literature where he showed that in high-risk patients, given the post-operative Duracef afterwards, improved.
So the high-risk patient.
Yeah. No. I'm just saying that's the literature.
Kevin,
had
you
said
may
there
be
was
high
none.
risk because of your morbidities and your mask, but the rest of us.
So just wanted to give a shout out to the consensus meeting that had shoulder and elbow consensus infection in Philadelphia. I wasn't at the meeting, but Grant was. He maybe can expand more on it. But John, it was a great talk. Give you a 9.
9. Nice.
Great talk, John. I'm really glad I didn't have to give that talk in 3 minutes. Question, do you use isolation suit in the OR on totals, and do you think it helps with infection risk?
No, I don't use them. Do you use them at all?
Raise your hand if you wear a hood. Wow. That's a surprise. Majority. Wow. It's a majority.
Raise it. Raise if you wear a hood just to keep the spray out of your face.
Wow.
This is majority.
Majority.
So, Paul, who restricts flow in and out of the room? I mean, I've noticed that when I'm paying attention, people walking in and out of the room, actually, does it matter? And, I mean, should I be restricting that? John, what do you think?
Yeah, a number of my partners just have signs on the door that basically say arthroplasty procedure and process do not enter the room.
You just see random people.
Oh, I know.
coming
It's
out
a
of
big
the-
problem. It's a big problem.
So
I had a quick question.
George wants you to lock the door. I suspect that some compliance officer, I mean, I saw you do that last night with someone, but.
So they used to use UV light in the OR, and people thought that it was the UV light killing the bacteria. And then they realized it was no, people didn't want to come in the OR because they get a sunburn and skin cancer. And they found out that the OR traffic is way lower when you have these UV lights on.
So
and that
skin-
was actually what was causing the decreased infection rate in the
So
UV
skin
room.
cancer keeps you out of the infection rate.
I just had a quick question for Dr.
Wait,
Sperling.
Danny, hang on. Can you tell us about your experience on Family Feud yesterday? The only person that was worse than you was the person who drafted you. Fido and the guy, I mean, how can you not know? How can you not know DJs? Look at you. You got like no shirt on, sunglasses.
Avicii was my answer. I just had a quick question for Dr. Sperling. When you have an acute infection on the reverse, like the hip and knee guys always change the poly, are you routinely also changing the sphere?
Yes, I'm trying to do that as well. So we'll pop out the poly, take out the sphere, wash the joint out, and then at Mayo we tend to be pretty aggressive then in terms of IV antibiotics for those patients.
Thanks.
Graders,
So 10 out of 10. The other question I have for you, are you doing some things like I routinely change my gloves? I just don't know how other people are doing that or if they're doing it frequently or infrequently during the case.
Changing gloves, raise your hand if you, at what point?
So usually before the implants.
Right before you final implant.
Between
One, change gloves. Does anyone use a deep knife? Do you change knife after skin incision? Yeah. So that seems to be percolating up a little bit too. What about IOBAN drapes? So that seems to be pretty uniform. Do they stick to the skin and rip the skin off those skinny little old ladies and cause you blisters instead? Oh my gosh, Dr. Zoomstein is going to quote a paper from the Cochrane Review. Can we have the airborne? No, I want you to cite the literature. And I don't know, not everyone in the back can hear you.
It's not only me, it's George who said the same thing. So there is literature which increases the infection rate if you use IOBAN.
So
it's a point of discussion.
So this
Cochrane Review, Gurriwal et al.
Cochrane Review, right. So the question that arises is Cochrane Review looked at this and said there's an increased rate. Now, it's not a perfect study, but that said, so George, you do not use an IOBAN. Matthias, you do not. So majority of the room uses it. You've got two world leaders here telling you it increases your infection rate. How do you reckon? Jerry, how do we reconcile?
I guess it's impossible to recognize. I'm not sure I believe the data, to be honest with you. I mean, the Cochrane database is a compilation of papers. If you compile crap, you get crap. So I have not really looked at what they.
Is he goddamn brilliant or what? That guy taught me everything.
There's a lot of stuff that's come out of the Cochrane database that I don't believe.
He called George Atwell crap. I'm really upset about
No, I didn't. I did not. I called the Cochrane database crap.
Fine.
Paul, one other thing. The Mayo Group showed the suction tip. If you culture the suction tip at an hour into a case you're doing, it's a cesspool. So it's another thing I just change it if I'm at an hour.
The other thing is tagging the subscap muscle early on. If you culture the subscap stitch throughout the case, that's positive as well.
I mean, how do we get through a case without them all pussing out? I don't understand.
If you use your left hand to operate, you have more infection too. What the hell are you talking about, Paul? Can you get on some data shit?
Sorry, Joe, we're actually citing data. It's unusual. All right, so look, one stage versus two. Oh, I'm sorry.
Paul,
hey, Johnny.
Has anyone had any experience with an Alexis soft tissue protector, which is sort of a soft tissue sleeve that you can put in? The general surgeons use it. The hip guys are starting to use it. I've been using it for about 5 years. I soak it in Iricept solution, fold that right in there, protects all your instruments going in and out of the wound all day long. Works phenomenal.
Do you guys know about this? It's one of the hernia.
Does not block the exposure.
It was designed for hernias. It goes in and expands in your wound.
It's called an Alexis soft tissue protector. I have no financial.
How much does it cost, John?
It's about $400 for a box of 6, I believe.
So let's just touch on single stage versus two stage. John, you alluded to that you're more inclined, at least with the nature of the patients that you see, to do two stage because it's been sort of festering. Let's go on these guys here. Grant, Joe, Jay, Wasim first.
Well, it's not Wasim, it's Wasim.
Wasim.
Okay.
When I was training with Dr. Weider, we were doing a single stage mostly, unless it's a very bad infection.
So let me expand on that. So if the prosthesis is loose, it's all coming out. I used to do a lot of two stages, but taking out well-fixed implants in the shoulder is difficult, and you can destroy the glenoid and destroy the humerus and then really complicate your reimplantation options. So for me now, if the implant is well-fixed, I do a one stage. It doesn't always work, but sometimes it does, and if it doesn't work, then I'm okay going back in and later ripping it all out.
Jay?
Mostly two stage. I would say if it's an indolent bacteria and a healthy host, I'll single stage it. But if it's neither of those, it has to be both of those, or else I'll two stage it.
Joe, Grant?
Most of the infections I encounter are low virulence, so one stage, but a high virulent organism, two stage.
So Dr. Zuckerman is asking me to clarify what I am implying by one versus two stage, and I appreciate that. So.
Yeah. So I think you're talking about taking out all the modular components, washing everything out, and leaving the well-fixed components. But oftentimes in the literature, one-stage exchange is taking everything out and putting another one back in at one stage. So I just think you should clarify exactly what you're saying.